So we'll start with the quiz related to healthcare quality basics and leadership. So here's our first question for today. I mean, like once I read the options, I expect the participants to give their answers and then we'll evaluate the options for the right answer. Okay. So the first question is managed competition in healthcare most often refers to. Okay, so it's in a way like the direct sort of definition question. What does managed competition means? Option A, healthcare providers administered by competing management companies. Or option B, healthcare providers competing by type of specialty. Or option C, grouped healthcare providers competing within a geographic region. Or option D, managed care organizations. What's the right answer? Okay, so you're going with C. Yes, option C is the right answer. Now we will see why the other ones are not the ones, not the right answers, right? So here option A is healthcare providers administered by competing management companies. Okay, so this is more of a corporate management competition, right? It's the competition between the corporate managements. Okay, who actually run the providers? This is not the competition among the providers themselves. So uh, we are not going to go with this option. This is eliminated. Option B, healthcare providers competing by type of specialty. See, I mean, by type of specialty means a competition between cardiologists or competition between orthopedic surgeons or cardiologists versus orthopedic surgeons. So this is not a managed competition, right? So this also doesn't fit into the definition. Option C is grouped healthcare providers competing within a geographic region. Yes, this is the definition of managed competition. Okay, so managed competition, I mean, like it's a concept that divides the healthcare providers within a community into competing economic groups within a given geographic region. Okay, so they use market forces to motivate them to be more efficient and to also to drive better quality and give better quality care, right? So that's the precise definition of what managed competition means. Option D is managed care organization. This is completely a different concept. Okay, managed competition is not managed care, though you might be tempted to go with this trap of having the same word, but no, these two are completely different. Managed care is a delivery system, whereas managed competition is a market strategy. Okay, that is that uses the competing groups of providers to drive better quality and cost efficiency. So this is also not the right answer. Option C is a right option. Now, in a way, like for you to remember, so for you to remember, this is precisely the definition of managed competition. Okay, it's more of a sort of strategy, right? So it's why exactly this was designed. This was designed to obtain the maximum value for consumers and also the employers by in a way like managing or by structuring the competition among organized groups of providers within a given geographic area. Okay, so in simple terms, like let's say in a given city, right? So there are three sort of what do you say, healthcare providers. Okay, an insurance company or an insurance. See, three different healthcare providers, three different companies, but all three are within a given geographic area, right? Healthcare insurance has contract with all these three hospitals or healthcare providers. Okay, they negotiate their rates and in a way like they will also look at the quality of care that is being provided within these providers and negotiate their rates accordingly. Okay, so by doing that, they are giving the option for the consumers to choose one among the three, and they will in a way like they encourage the consumers to opt for the provider which is providing better quality at efficient rates. Okay, here the insurance is creating a sort of competition between three healthcare providers within a city. Within a city, this is a manufactured competition because the providers want the consumers to walk into their premises because they want to attract the consumers to avail their services. Obviously, they will go for better care, better quality, and at efficient rates. I hope you got what exactly the managed competition means. Okay. This should be within a given geographic region, and it's a competition between healthcare providers by the payer or a insurance provider, in short. Okay. Now, coming to the next question. In managed care, the most common form of reimbursement for primary care physicians is, okay, it's like most common. It's asking the most common form of reimbursement for primary care physicians is it a straight salary? Is it capitation without withholds? Capitation with withholds? Or is it discounted fee for service? What's the right answer? Someone?
Yes, capitation with withholds.
Capitation with?
Withholds.
So you're going with option C, capitation with withholds. Yes, that's the right answer. See, the question is asking like in managed care, how are physicians paid, or how do the how are the physicians how physicians get their primary care physicians get their payment. It's asking the most common form. See, the most common form means there are various forms of payments that they do get, but it's asking what is the most common form. Okay, so in managed care, option A, straight salary. See, straight salary is like they are working for salary. In some sort of settings, they do. I mean, like primary care physicians are direct employees of the providers, direct employees of the managed care HMOs. So this is present, but this is not the most common form across the managed care. Okay, so this is eliminated. Capitation without withholds. See, pure capitation, we have already gone through what exactly capitation means. Capitation means there's a fixed payment per member per month. Okay, so without withholds means 100% of the payment is done to the physician. Okay, so here by doing so, the managed care organization loses control over this mechanism, right? So in a way like this may be present, this form of payment may be present, but again this is not the dominant or the most common form of reimbursement for primary care physicians because they don't have any sort of control over the cost efficiency or anything over the primary care physicians. If at all, they pay without withholds. And what is discounted fee for service? So discounted fee for service means like it's more of a, what do you say, it's association more with preferred provider organization. Okay, where the providers agree to a discounted rates, but it's not exactly the characteristics of the HMO or managed care. Okay, so we are going to eliminate this option as well. Coming to option C, capitation with withholds. Now you need to understand capitation with withholds. Here there is capitation, like there's a fixed per member per month payment. Okay, so that is fixed, but what happens is the what do you say, the payer will withhold a certain portion of the payment and will put it in a risk pool. And if the physician meets the cost or utilization targets, then the withheld payment is paid at full at the end of the year, right? In a way, like, I hope you understood. There's a small percentage of the payment is withheld and is placed in a risk pool. And then if the physician meets certain targets of cost and utilization, then the withheld money is returned at the year end. By doing this, in a way, like, there is a predictable income to the primary care physician, and if he does achieve the target of proper care, in a way, like, with the number of referrals below the target, and then if he's managing efficiently, then the remaining withheld payment will be paid to him at the year end. In case if he crosses that limit, then the withheld are not paid. I think you got the point. Okay, this is more of a, what do you say? Uh, Withholds are like something like a sort of accountability. Okay, let's say, for example, for you to understand, let's say there's a primary care physician. Okay, so for him, he receives somewhere around $25 per member per person per month. Okay, per person per month. Okay, $25, and there are somewhere around 500 patients enrolled for him. That comes somewhere around $12,500 per month. Okay, so regardless of how many visits may occur, he is going to get 12,500 per month, according to what we know regarding the managed care, right? But here, regarding capitation. Now, here, what happens is, out of the 12,500, let's say somewhere around 20% is withheld into a risk pool. What happens is, he will be receiving 10,000 as payment per month, okay, overall, but the remaining 2,000 per month is held as a risk in the risk pool. At the end of the year, if he, I mean, like, they will look at his statistics, they will look at his performance, how well he's utilizing, how well he efficiently managing the care. Okay, so they will look at the panel specialist referrals, hospitalizations of the patients he's managing. Are they within the target, or it has crossed? So once they are within the target and he is doing good, then he will get back his 2,000 into 12, $24,000 full back. If not, a part of that will be deducted. In a way, like, this helps in incentivizing the doctor to manage care very much proactively and cost consciously. Okay, so that's the entire concept of capitation with withholds. Now, coming to the next question. Outside the US, most industrialized nations offer which type of healthcare insurance? Is it universal coverage? Is it employer based coverage? Is it managed care or managed competition? What's your answer? Anyone?
Yeah. Universal
Okay.
coverage.
Right. So the answer is universal coverage. So here, most industrialized nations, means developed countries like United Kingdom, Canada, Germany, France, Australia, Japan, etc. So here, most industrialized nations. Okay, United States is an exception for this type. Okay, right. So virtually every major industrialized nation outside of the US provides universal coverage, universal health coverage. This means all residents, all citizens are covered within their health scheme, the government sort of health coverage, regardless of their employment, income, or health status. Okay, so for example, like NHS Trust in United Kingdom or Medicare in Canada. Okay, or you'll see similar things in Germany, France, Japan, Australia, etc. So universal coverage is the one which is not present in United States but present in most other industrialized nations. So this is the right answer. So now what's employer based coverage? See, employers based coverage, this is very much a hallmark of United States, right? So most of the Americans receive their insurance through their employers. That's employer based coverage. Okay. Other nations may have employer contributions, but universal coverage is the defining feature of the system. So this is the right answer. Now coming to managed care, again, this is again an American model. So managed care is a formal structure within the US. Okay, now managed competition, we have already discussed this, that this is not a sort of, it's more about, what do you say? Again, this is more present in United States itself, not the dominant model as far as other industrialized nations are concerned. So I'm not going with these options. And the correct option is option A, universal coverage. So there are certain questions wherein there's not much to discuss regarding the concept. For that, I'll try to be as much straight as possible. Okay. Now, the most basic components of managed care include all except. So here the keyword is all except, right? Basic components of managed care. Is it prepaid financing? Is it comprehensive services at multiple levels and settings? Is it controlled access to services? Or is it broad choice of providers? What's your answer?
Letter D.
Option D, broad choice of providers. Yes. So the question is basically asking, the list over here has the basic components of managed care, except one which is not. Like one out of all these four is not present in or not the basic component of managed care is the one understanding of the question. See, prepaid financing means here members pay premiums in advance, prepaid. MCU manages care within that budget. Okay. This is a basic component of what managed care is. We all know. Prepaid financing is there. Comprehensive services at multiple levels and settings. Yes, managed care systems aim to provide the full spectrum of services, right from preventive, primary, specialty, rehab, etc. Right. So comprehensiveness there is there at all levels. So this is also the right statement regarding managed care is concerned. Controlled access to services, absolutely, because this is one of the aims of the managed care actually. So in a way, like here in managed care, primary care physician acts as a sort of gatekeeper, and only if he refers to any specialty, then you are allowed to obtain that service. If not, no, right? So and you also know that he will be referring to the specialist within the network itself, right? So this statement is also correct, and by that itself we will come to know that the choice of providers in managed care is narrow. We have already discussed this in our last session, right? So this is broad choice of providers is not the feature of managed care. So this is a wrong statement regarding managed care. And when it's asking all except, this is the right option. Okay. So I hope you understood this question. Now, coming to question number 35. Who is responsible for providing CQI direction? Is it the facilitator? Is it the quality council? Is it the leader? Or is it the team? What's the right answer?
Quality council.
Quality council. Anyone to differ? Okay. No. So the answer is B, quality council. So here it's asking who is responsible for providing CQI direction. So direction means, they are setting purpose or they are prioritizing things at a strategic level. So it's a sort of governance and leadership function, right? So out of these list, facilitator. So who is a facilitator? Facilitator guides the process of team meetings and QI activities. They do help teams work together. And one of the main role of a facilitator is to keep the discussions focused and not wandering here and there. And he will ensure that the correct tools are used, right? So in a way, like facilitators enable CQA work, but they do not direct it strategically. That's the difference, right? So, but the question is regarding the direction. So facilitator is eliminated. Now, quality council. See, quality council, we also know it's called as steering council, quality steering council, or apex quality council, or CQO council, whatever you name. It's the highest body responsible for providing CQI direction organization wide. And it is the body which sets the vision, mission, strategic, and the direction for all the CQI work within the organization. They oversee or they supervise, they oversee the QI initiatives, they allocate resources, they will prioritize things as far as CQI projects are concerned. That's the role of quality council. It's more like a governing body for what do you say, quality is concerned. Within an organization, that's an analogy which I'm trying to make. So quality council is the right option as far as providing CQI direction is concerned. Here's a trap: you may be tempted to go for it, for this option, right? Few may choose, but here the term leader is very vague. It's not I mean, like, it's not providing the information whether it's a departmental leader or at a higher level. Okay, it's too vague here. Whatever it is, even if they might have what do you say, provided any specific, the option would have been still quality council. But remember, individual leaders implement and champion CQI, but the overall direction stays with the what do you say, quality council, right? And option D, team, it's more of an implementing improvement projects. They test the changes, analyze data, execute PDCA or whatever. They are more operational and not at the strategic directional level. So I'm going to eliminate this option as well. So the correct answer is option B, quality council. Now, coming to the next question, this is scenario based. You have joined the newly merged Preferred Health for-profit integrated delivery system as a VP of for quality. You are responsible for engineering or otherwise integrating QI QM function across the provider network. Based on your understanding of systems, corporate culture, ethics, quality, leadership's influence, and strategic planning, answer the following question. Of the following options, the measures most indicative of IDS ability to provide value to its stakeholders are, okay, the options are improvements in patient outcomes and reduced cost of care. Option B, an annual report with a positive bottom line. Option C, improvement in patient outcomes and patient satisfaction. Option D, reduced cost of care and competitive pricing. The measures most indicative of ability to provide value to its stakeholders. What's your answer?
Letter A.
C.
Okay, you're going with option A, improvement in patient outcome and reduced cost of care. So now, in a way, like, let's see why option A is the right answer and why not the other ones. Okay, so as VP for quality at a for-profit integrated delivery system. Okay, so which combination out of the following best shows that it's delivering real value to its stakeholders? Okay, now the thing is value to its stakeholders. So who are the stakeholders and what is value? This is what you need to understand first. Okay, value must be defined from multiple stakeholder perspective. So you need to know who are the stakeholders. You see, this is a for-profit organization. So in a way, like, here the stakeholders may be patients, payers, employers, the community, the governing body, everyone, right? So they're all the stakeholders. Now, when you imagine that, IDS is for profit. When for profit, we have to think that it has financial obligations and also clinical quality obligations. That way, I'm going to cut short or reduce my narrow my focus down to the options now. See, Option B is annual report with a positive bottom line, right? Here, I mean, like positive financial statement shows that the financial health is good. It talks about, I mean, like, but it talks in terms of finances only. Okay, it tells stakeholders nothing about clinical quality or patient experience. It's only talking about the finances. Okay, so remember, financial performance alone is not value. So I'm not going to go with this option. Improvements in patient outcomes and patient satisfaction. See, uh, in a way, this combination captures quality and experience both. Okay, but it is not talking about cost or efficiency dimension. There's no financial thing that is involved, though this is in a way like a good closer one. Okay, now in a way like think about the definition or the formula or the equation for value which we have discussed in our first session, quality by cost. Okay, there it was talking about quality and also cost. So here, in a way like for us, you see, value in healthcare, we told that it's quality by cost or quality outcomes by cost. So value in healthcare is outcomes achieved per every dollar spent in that way, right? And patient satisfaction without cost improvement is incomplete value measurement for us. So still, this is closer, but it's not giving the full scope for us. Now, reduced cost of care and competitive pricing. Again, so cost reduction does matter. It's talking about what do you say, value is equal to quality outcomes by what do you say, cost. It's talking about the cost of care and competitive pricing. It's talking about this, but it's completely leaving out the quality outcome thing. So I'm still not going. This is incomplete one. So improvement in patient outcomes and reduced cost of care is the nearest option which is correct. So this is the most complete. Okay, so remember that value is equal to quality by cost. Okay, this is what it tells us here. Improvements in patient outcomes, it's talking about both. Improvement in patient outcomes is quality and reduction of cost. Reduction of cost and improvement in quality is giving a positive value, a greater value, right? So this is this is where the true value lies. Any doubts regarding this? I hope I was clear regarding the concept for this particular scenario. Now, coming to the next question. Who is ultimately responsible for the effective implementation of quality program? Is it governing body? Is it CEO? Is it all staff? Or is it the CFO?
Governing body.
Governing body. Right. So here again, we have already spoken about this particular thing many a times in our previous sessions. So the ultimate responsibility for quality lies with the governing body. Okay. So CEO is more of an operational guy. So he runs the day-to-day operations of the organization, but he's still answerable to someone above him, that is governing body. Okay, so he's not ultimate responsible person. And all staff, absolutely in CQI, every staff is responsible for quality, but ultimate responsibility lies with the governing body, right? CFO, this is more of a what do you say, finance related. He is in a way like the person who enable he is an enabler of quality program by allocating the resources and budget, but financial management is not quality governance. Okay, so in a way like I'm not going with these options. And governing body is the highest legal entity of the organization, and they are legally responsible for everything that happens within the organization, and they're ultimately responsible for quality care as well. Okay. And remember, even Joint Commission also states this. Okay, or any for that matter, any accreditation body does recognize the governing body as the ultimate responsible entity for the quality improvement in the organization. There's no doubt about it. Now, question number 38. So, the principle underlying the selection of an organization-wide quality council is like, what's the fundamental principle or idea behind having one single organization-wide quality council? What's the role? Why exactly is that? Okay. Option A, one oversight body, or for leadership control, or one cross-functional team, or elimination of department or service control team, service quality control. What's your answer? Anyone?
Not agree.
Option
C.
A. Right. So this is the core principle. The question is asking like, what's the idea or rationale, or how do you justify by having one single organization-wide quality council? Okay. What's the role? Why should we have that? Okay. So the aim is having one single highest quality council in an organization to have one oversight body. Okay, this is foundational principle behind the quality council. So in a way, like see, the rationale is unified quality council, having a unified quality council rather than having separate department based quality committees. Now think about it. If you have 10 to 12 departments, is it wise to have 10 to 12 quality committees, or one which oversees every departments and everything? It's logical that one central authority provides us with consistent, coherent, and the organization wide direction, or the one who oversees all the quality activities. That's practical because this prevents fragmentation. This also prevents duplication, like same sort of the work done twice. And also, most importantly, it removes the competing quality agendas. When we have silos, when we have different departmental level committees without any overseeing body, what happens is there may be conflicting or competing quality agendas. One department wants to prioritize one initiative, and the other one may opt for another initiative. There is no coherence, there is no consistency also. So in that way, one oversight body is absolutely practical and a must. Now, leadership for leadership control, see, leadership is essential, but he is talking about the leadership control. I mean, like this is more of a top-down approach, and for CQI and control, sometimes that doesn't go hand in hand. Okay, so this is not going to be the right option. One cross-functional team. See, quality council is not a cross-functional team. Okay, so it's a governance and oversight body, not a project team. So don't fall for the trap. If you may be tempted to go for this one cross-functional team thing, but that's not the aim for us. Okay, elimination of department service quality control. In a way, like see, this is opposite of what happens in a way, like an organization-wide quality council does not eliminate department level quality work. It just coordinates and oversees it. Okay, don't fall for this trap. One single council doesn't mean that we don't have department level quality teams or quality committees. Okay, there may be many, but there is one superior, one single body which oversees all those activities and which coordinates all these efforts. Okay, so I'm not going with this one also. The correct answer is option A, one oversight body. Okay. Now, as Director of Quality Resource Management for an integrated delivery system, you have been asked to provide information prior to renegotiation of a contract with a national preferred provider network. What data will be most helpful? Is it reimbursement minus charges, reimbursement minus costs, charges minus reimbursement, or charges minus costs? What's your answer?
Letter B.
Option B, reimbursement minus costs. Right. So here the question is simply asking like there's a scenario. Okay, you are going to have a renegotiation of a contract with preferred provider network. Okay, so before going for this that renegotiation, what financial data is most helpful for you to know? Okay, so there are the formulae in a way, like four options of the formulae. So here reimbursement means in a way like, see, before going there, I'm going to talk about what are the terms that we are going across. Reimbursement means what the payer actually pays you for the services. Okay. Charges means this is what you bill for your services, right? And costs mean what the, I mean, like what are the expenditure of the cost, real expenditure, and what it costs you to deliver the services. Okay, there are three terms that we are supposed to know. Reimbursement means what the payer pays us, charges means what you bill, and the cost means what is actual expenditure, the real expenditure. Okay, now coming option wise, let's say reimbursement minus charges. See, reimbursement minus charges sometimes would give you a negative number. I mean, like in most of the cases, also it may give a negative number for us because charges are always higher than reimbursement. See, a patient has come to your organization, he has taken service. Okay, for all the services that you have provided, you might have charged him somewhere around $10,000. Now, do you really feel the payer is going to pay you the same amount? No, for that particular diagnosis related group, he might be paying us somewhere around 7,000. So 7,000 is reimbursement, 10,000 is the charges. So see, here reimbursement minus charges is 3K minus $3,000, right? Reimbursement is, sorry, 7K, charges is 10K. You are billing that particular person $10,000, but the provider is giving you $7,000. So this gives minus 3K. So is it going to give you any sort of what do you say, insight into this? See, we always charge higher than reimbursement, right? So this, what does this tell? What does this 3K tell? This is more. This is talking more about what do you say, the discount. I mean, like discount the payer takes, it's not your profit or loss. For negotiation, this is not going to help us, right? Now, charges minus reimbursement, again the same thing, but in a reverse way. This gives 3K. But is it going to, this, is this information going to help us out somewhere? No, again. Okay. Now, charges minus costs. If I calculate the cost of the care that I have provided to that particular patient, that may be somewhere around 5K. Let's assume. Okay. Now, charges minus cost. This charges is 10K minus cost is 5. This is giving you $5,000. Okay. What is this giving? What is this figure giving? This is merely giving us a gross profit potential, right? The maximum if I can earn if the payer is reimbursing it in full. But you all know that payers don't pay in full. Okay, this is more of a theoretical figure. And they are going to reimburse me only 7K. So this is a theoretical figure. This is also of no use. Now coming to the second option, reimbursement minus cost. Reimbursement is 7K minus cost is 5K. In this scenario, I am getting 2K as the answer, and this is actually my profit. Okay. Similarly, if at all my cost is high and reimbursement is lower, then I may be getting somewhere around, okay, if my cost is 8, okay, 7 minus 8 is 1K. I'm getting a loss of 1,000. If I get this information, if I get this the data of this particular information, this data, this will help me prepare myself for a renegotiation. Okay, so the correct option is a reimbursement minus costs. Now, like, do you have any doubt regarding this particular question? If so, please ask. Okay, I assume no. So by having this profit margin, remember, before going for the renegotiation with the payer, you will have a sort of leverage because there is evidence, there's analysis that you have done. That leverage will help you, or it will save you from losing money. Okay, so this is all is documented, everything is available, all evidences are present, and if you are actually making loss, this is your chance at the time of renegotiation itself to increase the payout for from the payer. Okay, and in a way like this also gives you confidence in negotiation that you do know what exactly is happening, and you'll go across confidently and negotiate for a better sort of pay. Okay, now coming to the last question of the quiz. According to TQM principles, manager should he lead with autocratic decision making? Should he communicate successes or failure only to the boss? Or lead with participative decision making? Or focus on short term financial impact of quality improvement techniques? What's your answer?
I think C.
Sorry? Option?
C button.
Option C, lead with participative decision making. Okay. So, see, here we are talking about total quality management, TQM. So it's like a comprehensive organization wide quality philosophy, and here it's asking according to TQM principle. So the answer must align with the TQM's core value, not according to your general management preferences. Okay, so how should a manager be, or what style should he have? So option, let's go through the options. Lead with autocratic decision making. See, autocratic decision making is effective in crisis situations. And we all know total quality management is explicitly and fundamentally opposed to autocratic management. Right. So, in a way, like Deming, out of all the points, Deming always says to eliminate the fear, to build the trust. Okay. So, autocratic leadership doesn't fit with TQM sort of principle. So I'm going to eliminate this particular option. Communicate successes or failures only to the boss. See, only to the boss. See, this is more of a secretive or upward communication. And whereas TQM talks about transparency, it's about open communication. It's not a selective or narrow communication thing. Okay, so TQM requires sharing data and results, and what is it, announcing it organization wide so that everyone can improve. Okay, so again, this again goes against the TQM principles. Option D, focus on short term financial impact of quality improvement techniques. Again, we all know that TQM focuses on the long term thinking, and TQM prefers long term over the short term gains. Okay, so in a way, like we are going to eliminate this option as well. The correct option is option C, lead with participative decision making. Now, why does this work? Because in participative leadership style or participative decision making, you involve the end user, you involve the people, you allow them to put forward their opinions. In that way, you are building trust. There, in a way, like you are building the ownership for the decisions which you are going to take. Okay, still you are going to retain the final call, but you are involving people, you are respecting them. Okay, and you are making them feel that it's everyone's job, right? So this is the best way of or the best way of best style to go with TQM principles. Any doubts? Okay, so I assume there are no doubts, and I'm going to go with the next session now.